Good afternoon. So my topic is clinical outcomes of CRETAN protocol versus Athens protocol in the treatment of progressive. Okay. I have switched it. Good afternoon. So my topic for today is clinical outcome of CRETAN protocol versus Athens protocol in the treatment of progressive keratoconus. So as you all know, keratoconus is a progressive corneal disease leading to irregular astigmatism and reduced visual acuity. It begins during adolescence and progresses until third and fourth decade. Incidence rates varies by region, and in India, keratoconus manifests earlier and advances more quickly than in Western countries. This is a five-point algorithm for the management of keratoconus, in which if there is a high-risk progression for keratoconus, collagen cross-linking can be directly considered, and visual rehabilitation with spectacles and contact lenses can be done. If there is a low to moderate risk of progression, contact lenses can be tried first, and then if there is still a progression, and then contact lenses tolerance is present, then cross-linking can be tried. If there is if the contact lens is intolerant, then according to the corneal thickness, the further procedures can be carried out. The purpose of the study was to evaluate the visual and clinical outcomes of CRETAN protocol versus Athens protocol in the treatment of progressive keratoconus. So it was a prospective interventional study conducted in a tertiary care hospital in Bangalore that included 30 eyes of progressive keratoconus with corneal thickness of more than 450 microns. Preoperative evaluation was done, and then patients were randomized into two groups, out of which, that is 15 eyes, one of the group underwent Athens protocol, that is topography guided partial PRK with collagen cross-linking. The other 15 eyes were taken up for CRETAN protocol, that is transepithelial PTK with collagen cross-linking. And then they were followed up at postoperative week 1, 3, and 6 months. And during the follow-up, UCVA, the best corrected visual acuity, keratometry readings, corneal thickness, and manifest refraction spherical equivalents were calculated. So all the procedures were done by the same surgeon at the same institute. Coming to CRETAN protocol, under topical anesthesia with proparacaine eye drops 0.5%, transepithelial PTK was done to remove corneal epithelium at 6.5 to 7 mm zone at a depth of 50 microns for each patient. And then epithelium was mechanically enlarged by scraping at 8 to 9 mm zone. Collagen cross-linking was then performed with riboflavin 0.1% using isotonic solution for the corneals with thickness of more than 400 microns and hypotonic solution for corneas with thickness of 350 to 400 microns. And then cornea was aligned for UV irradiation of 365 nanometers for 30 minutes at an irradiance of 3 milliwatt per centimeter square. And then bandage contact lens was put until the epithelium healed. And then coming to Athens protocol, under the topical anesthesia with proparacaine eye drops, customized topography-guided partial PRK was performed according to the intended refractive correction on the 6 mm optical zone. Mitomycin C 0.02% application was done for 30 seconds. Collagen cross-linking with riboflavin 0.1% solution with isotonic solution for residual stromal bed thickness of 400 microns or more, and using hypotonic solutions for corneas with residual bed thickness of 350 to 400 microns was done. Cornea was then aligned for UV irradiation of 365 nanometers for 10 minutes at an irradiance of 9 milliwatt per centimeter square. And then bandage contact lens was put until the epithelium healed. So the results, these are the results, and the study included 30 eyes of 24 patients with progressive keratoconus. There was a statistically significant improvement in mean logmar uncorrected visual acuity and also mean logmar best corrected visual acuity in both the protocols, the details of which will be explained in discussion. The keratometry reading showed a reduction in the flat K, steep K, and also the maximum keratometry values post the procedure. And there was a reduction in corneal thickness also. Manifest refraction spherical equivalent, there was a reduction from minus 3.69 to minus 3.39 diopters in CRETAN protocol group, and minus 3.68 diopters to minus 2.31 in Athens protocol group. 6.7% of the patients showed mild steroid response at 1 month follow-up, and 6.7% of the patients showed mild corneal haze at 3 months post-op. None of our patients showed any signs of keratoconus progression during the follow-up period. Coming to discussion, in a similar study that was conducted by Antonis et al. On the long-term results of CRETAN protocol in progressive keratoconus, maximum thickness of stromal aberration was 50 microns. And then logmar uncorrected visual acuity, there was a significant improvement from 0.99 logmar units to 0.61 logmar units, and BCVA from 0.27 to 0.17 logmar units. There was a reduction in the mean K, flat K, and also the maximum K values at the last follow-up, that is at 4 years of follow-up examination. However, the corneal thickness did not show any changes in the post-operative examination. In our study, the thickness of stromal ablation was the same. It was restricted to 50 microns. 53.33% of our patients, they gained at least one line of UCVA, and 26.6% gained at least one line of BCVA. The maximum keratometry reading, it reduced by 0.2 diopters. There was a significant reduction in mean CCT also. There was a significant reduction in the manifest refraction spherical equivalent from minus 3.69 to minus 3.39 at 6 months of follow-up. This is the pre and post-op topography reading of a patient who underwent CRETAN protocol. And coming to a similar study pertaining to Athens protocol that was done by Sakla et al., maximum corneal thickness, thickness of ablation was restricted to 50 microns, wherein they noticed a significant reduction in the UCVA, BCVA, mean K and flat K values. In our study, the thickness of stromal ablation ranged from 44 to 83 microns. 46% of our patients gained at least 2 lines of UCVA, and then 53% gained at least 1 line of BCVA. Mean K, steep K decreased from 2.99 diopters and also 3.56 diopters post-op. There was a reduction in CCT from 457 microns to 368 microns. There was also a significant reduction in the manifest refraction spherical equivalent from minus 3.68 to 2.31 diopters. This is the pre and post-op imaging of a patient who underwent Athens protocol. So I would like to conclude that CRETAN and Athens protocol are both safe and effective surgical treatment options for early progressive keratoconus, capable of offering patient the stabilization of their rectilighting disorder and also functional vision. However, Athens protocol, it offers better visual rehabilitation compared to CRETAN's protocol. And the further studies with larger patient series and longer periods of follow-up are required to confirm the outcomes. These are my references. Thank you.
Thank you. Anything that you feel you would like to add as a limitation or challenge in the study?
Limitations were the number of patients we did this study on. It could have been more, and the follow-up is of this presentation was done for like 6 months of follow-up. We could have followed up for more.
Okay. Thank you.